Usually when we talk about a medical diagnosis or some bodily system, there's this expectation of clinical precision.
Right, like it feels like engineering almost.
Exactly. I mean, you break your arm, the x-ray shows that jagged white line of the fracture, and the doctor just points to the glowing screen and says, well, there it is.
Broken or not broken, it's clean.
Yeah, it is deeply comforting to have that binary reality. We like things to be visible, to be categorized neatly into a rigid box.
It feels manageable because you can see exactly where the structural failure occurred. You point to the exact millimeter of a fracture on a fibula, and you know exactly what the mechanical fix is.
But then you step into the world of tissue integrity, and suddenly that x-ray machine is, well, it's completely useless.
Oh, totally useless.
We're looking at a diagnostic landscape that is honestly just murky. It's this constantly shifting battleground of microscopic flora, immune cascades, shear forces, and cellular regeneration.
It doesn't sit still for a snapshot.
No, it doesn't. If you are prepping to walk onto the floor for your clinicals tomorrow, or maybe you're staring down the barrel of your nursing boards, understanding this system is literally going to save your patient's life.
Without a doubt.
You are the learner, and today our mission is to completely master the concept of tissue integrity.
Whether you're prepping for a major exam or you just have this insane curiosity to understand the body's ultimate defensive barrier, we've got you covered.
Yeah, this session is custom tailored for you. We are going to serve as your intensive, high-yield guide. We've got a stack of comprehensive clinical notes and evidence-based practices here to go through.
And we are covering everything. I mean, from the microscopic physiology of the skin and how it drastically changes from the day you were born to your golden years,
Right.
all the way to the precise staging of complex pressure injuries.
It's a lot of ground to cover.
It is, but we are going to focus heavily on the pathophysiology, the actual biochemical and mechanical reasons why these tissues fail and how they rebuild.
So why spend an entire deep dive on what some people might just dismiss as, oh, it's just dermatology?
Because it's not just dermatology.
Right, it's a foundational clinical concept.
The integumentary system is an integrated, highly active organ system. It dictates thermoregulation, fluid balance, infection control.
Yeah. If a nurse doesn't deeply understand tissue integrity, they fundamentally cannot manage patient care. Because the moment the skin fails, every other systemic domino just starts to fall.
Rote memorization just fails under pressure.
It really does.
If you just memorize that a stage 3 pressure injury involves fat, you might panic on an exam or at the bedside when the wound looks atypical.
Exactly.
But if you understand the vascular architecture of the subcutaneous layer and why adipose tissue dies under shear force, that understanding sticks with you permanently.
You become an exceptional clinician, not just a test taker.
Exactly.
I love that. So let's get our definitions straight right out of the gate here.
Mm.
When we say tissue integrity, what are we actually talking about on a cellular level?
Well, our bodies have 4 main types of tissues, right? Muscle, neural, connective, and epithelial.
Okay.
When we talk about tissue integrity in this clinical context, we are specifically focused on epithelial tissue.
Just the epithelia.
Right. The core concept is the state of structurally intact and physiologically functioning epithelial tissues. This primarily means the integument, which is the skin and the subcutaneous tissue beneath it, and the mucous membranes.
Okay, so if you're struggling to visualize this, think of the integumentary system as a highly advanced suit of smart armor.
I like that analogy.
Yeah, it's not just a dumb piece of metal blocking attacks. It is actively managing internal climate control, like thermoregulation via sweat and piloerection.
Which is the medical term for goosebumps.
Right, goosebumps.
Yeah.
And it manages communications through millions of sensory nerve endings. Plus, it even handles waste disposal.
That dynamic barrier is constantly adapting. It provides absorption of needed substances, secretion into body cavities, and excretion of wastes.
It's doing a lot of heavy lifting.
It really is. And those sensory nerves provide a critical, real-time safety mechanism.
Like an alarm system.
Exactly. Nociceptors for pain, thermoreceptors for temperature, and mechanoreceptors for touch. They're constantly feeding data to the central nervous system.
So they tell a person about their environment so they can take action to prevent damage before it breaches the hull.
Right. Involuntary or voluntary action.
So let's break down the layers of this armor, because you absolutely have to know where the damage is to be able to stage it later.
Crucial for staging.
The top layer, the surface, is the epidermis. Underneath that is the dermis. The dermis has the small muscles, nerves, and sweat glands.
Yep, the engine room.
And then below that, the bottom layer is the subcutaneous tissue, or the fat layer, which is there for insulation and houses extra sweat glands. So let's look at the epidermis first. What's actually happening up there?
So the epidermis is a fascinating high vascular structure.
Avascular meaning no blood supply.
Exactly. It has no direct blood supply of its own at all. It relies entirely on the diffusion of nutrients from the dermis below it.
That's wild to think about.
It is. It's primarily composed of keratinocytes, which start at the bottom layer, the stratum basal, and they physically migrate upward over about 4 weeks.
Like a slow elevator.
Basically. And as they move up, they flatten, they die, and they fill with keratin, which is this tough, fibrous protein.
So by the time they reach the top...
The stratum corneum, yeah.
Oh.
By the time they reach the top, they are essentially overlapping dead, waterproof shields that constantly slough off.
It's a conveyor belt of microscopic shields.
Mm-hmm.
And we also have melanocytes in that bottom epidermal layer, right? Pumping out melanin to absorb UV radiation and protect the cellular DNA from mutating.
Yes, the built-in sun protection.
Then we drop down into the dermis, the functional engine room, like you said.
The dermis is highly vascularized. It is a thick matrix of connective tissue. It's primarily collagen for incredible tensile strength and elastin for recoil and flexibility.
So this is what gives skin its stretch.
Exactly. This is where the fibroblasts live, which are the cells responsible for building that collagen scaffolding.
Yeah.
It's where the piloerector muscles live that give you goosebumps to trap a layer of warm air. And it houses the immense network of capillaries that supply the epidermis above.
And then dropping one level deeper, we hit the subcutaneous layer, also called the hypodermis.
Right.
This is our shock absorber and our thermal blanket. It's loose connective tissue and adipose or fat tissue. It basically anchors the skin to the underlying fascia and muscle.
And, you know, the endocrine function of that subcutaneous adipose tissue is often overlooked.
Really?
Yeah, clinically, it is a massive reservoir for energy and plays a huge role in hormone synthesis. It's not just passive padding. It's a highly active metabolic zone.
That is so interesting. But here is a question that always trips people up. And we talk about skin, but we also emphasize mucous membranes as part of this epithelial integrity.
Right, they're crucial.
How do they fit into this armor concept? Because, I mean, the inside of my cheek doesn't feel anything like the skin on my arm.
Well, they are structurally different, but functionally connected. Mucous membranes are continuous with the external skin, but they line the areas where the body must open to the outside world.
Like the eyelids in the nose.
Eyelids, nose, respiratory tract, GI tract, genital area, the urethra.
Okay.
Instead of producing that dry, dead, keratinized layer like the outer skin, these specialized tissues secrete mucin.
Mucin?
Yeah, which combines with water to form a thick, slippery mucus.
So basically a wet defense system.
A highly specialized one, yeah. That mucus acts as a biological trap for environmental pathogens and debris.
Oh, wow.
It contains natural antimicrobial enzymes like lysozyme and massive amounts of IgA antibodies. They actively neutralize viruses and bacteria before they can cross the barrier into the bloodstream.
Nature's sticky trap. Now let's look at how this smart armor changes over time. Because age-related variations are incredibly crucial for pediatric and geriatric nursing.
The physiology is entirely different depending on the birth year.
Right. Let's look at infants and children first. There's this massive misconception that baby skin is just perfect and pristine.
Oh, soft as a baby's bottom, right?
Yeah. But functionally, infant skin is actually terribly ineffective at temperature regulation. It's a major vulnerability.
Infants are highly vulnerable because their barrier is structurally immature. They have much thinner, highly permeable skin compared to older children and adults.
So things pass right through.
Exactly. The cells in their stratum corneum haven't fully compacted yet. Plus, they have a significantly lower percentage of subcutaneous fat.
Meaning they lack that vital thermal blanket we talked about.
They do.
They also have a massive surface area to body mass ratio. They're essentially little radiators losing heat to the environment way faster than an adult.
Combine that massive surface area with increased permeability, and you have a recipe for profound, rapid, insensible fluid loss.
Water just evaporates right through their epidermis.
Right. This is why a pediatric nurse must monitor an infant's fluid balance and core temperature meticulously.
It's life or death.
It is. A minor environmental temperature shift that an adult wouldn't even notice can throw an infant into hypothermia.
Wow.
And regarding their skin texture, it's smooth and dry, largely because their apocrine glands, which are a specialized sweat gland associated with hair follicles, are completely dormant.
Which perfectly explains why teenagers suddenly deal with oily skin, acne, and body odor.
Yes, the puberty switch flips.
When puberty hits, the endocrine system floods the body with androgens. The apocrine and sebaceous glands suddenly boot up, go into absolute overdrive and start pumping out sebum.
That hormonal surge fundamentally changes the microclimate of the skin's
It
surface.
gets messy.
Very. The excess sebum creates an incredibly nutrient-rich environment for bacteria, specifically Cutibacterium acnes. This leads to the clap inflammatory response we know as acne vulgaris.
So the barrier goes from being dry and permeable in infancy to thick, oily, and hyperactive in adolescence.
Exactly.
Let's fast forward to the other end of the spectrum, older adults. We know the armor ages, but what is actually failing on a microscopic level?
Cellular senescence takes over. The aging process systematically dismantles the structural integrity of all three layers.
Starting at the top.
Right. First, epidermal turnover slows down drastically. Instead of a fresh outer layer every month, it takes much longer. This makes the skin thinner and more fragile.
And in the dermis.
The fibroblasts become sluggish. They produce significantly less collagen and elastin. This destroys the skin's tensile strength and its ability to snap back into place.
So that structural degradation is why the skin starts wrinkling or hanging loosely.
Yes.
But it's also about what's happening at the junction between the layers, right? The dermal-epidermal junction.
Yes, the root ridges.
Can you explain those?
Sure. In healthy young skin, the boundary between the epidermis and dermis looks like an egg carton. Deep, interlocking waves that tightly bind the two layers together.
Okay, I can picture that.
In older adults, those ridges flatten out. The junction becomes a smooth, weak line.
Oh, no.
Yeah, this means that even minor friction, like just sliding across a bedsheet, can cause the epidermis to easily shear right off the dermis.
Resulting in massive skin tears.
Exactly.
And the subcutaneous fat layer depletes, taking away the shock absorbers over bony prominences like the sacrum and heels.
That padding is gone.
But let's talk about the neurological and vascular degradation, because this is where the major clinical danger lies. Older adults have a diminished perception of pain, right?
They do. The sensory feedback loop we talked about earlier, it degrades. The peripheral nerve endings become less dense and less responsive.
That seems really dangerous.
This delayed injury recognition is lethal.
Wow.
Think about it. If a healthy 20-year-old sits on a hard fold in their bed sheets, within minutes their nociceptors scream at them to shift their weight because the tissue is getting hypoxic.
Right, you get uncomfortable when you move.
But an older adult might not feel that hypoxia. They might lie on that hard fold for hours until severe, irreversible ischemic necrosis has completely destroyed the tissue bed down to the bone.
Just because they didn't feel it. That is terrifying.
It is. And when the injury does happen, their vascular system is already compromised.
Right.
They have reduced arterial and venous blood flow to the tissues, which starves the area of oxygen and drastically delays wound healing.
And also, the sebaceous gland activity drops off a cliff. So instead of the oily acne of a teenager, older adults get that classic rough, dry, incredibly itchy skin.
Known clinically as xerosis,
Yeah.
yes. We also have to factor in the cumulative environmental exposure over a lifetime.
Like sun damage.
Exactly.
Yeah.
While genetics drive a portion of this aging, photoaging from decades of ultraviolet sun damage physically shatters the collagen matrix. It causes severe DNA mutations within the melanocytes and keratinocytes.
So because this anatomy changes so drastically over a lifetime, I mean, from the highly permeable skin of a newborn to the thin, dry, sensory-deprived skin of an octogenarian, the ways this armor breaks down are wildly diverse.
We can't just treat every wound the same.
We really can't. Which brings us to the 6 major categories of impaired integrity. Let's get into the mechanisms of injury. How does the barrier actually fail?
Clinically, we categorize tissue impairment into 6 distinct mechanisms: trauma or injury, loss of perfusion, immunologic reactions, infections and infestations, thermal or radiation injury, and lesions.
Let's start with trauma and injury and loss of perfusion. Trauma seems pretty straightforward. It's kinetic energy physically destroying the barrier.
Right.
It ranges from a superficial abrasion where a child scrapes their knee on the asphalt, all the way to a deep, penetrating laceration that goes down through the fascia. But clinically, we also classify an intentional surgical incision as trauma, don't we?
We do. The body doesn't know the difference between a sterile scalpel and a jagged piece of glass.
It just registers a breach.
Exactly. It just registers an acute mechanical disruption of the epithelial barrier. The inflammatory cascade triggered by a surgical incision is identical to the cascade triggered by an accident.
Okay, but loss of perfusion is an entirely different mechanism. And honestly, it is arguably the most insidious.
Absolutely. All epithelial and connective tissues require a continuous supply of oxygenated blood to maintain aerobic metabolism.
Right. But here's where I want to push back, or at least clarify something that seems contradictory if you're just reading a basic physiology overview.
Okay, let's hear it.
We know that the skin is actually highly tolerant of poor circulation compared to vital organs like the liver, kidneys, or brain.
Yes, that's true.
During times of systemic shock, like massive blood loss, the sympathetic nervous system will clamp down the peripheral blood vessels. It literally shunts oxygenated blood away from the skin to save the heart and brain.
Survival mode.
Right. And the skin survives this hypoxic state just fine for hours. So if the skin is so incredibly tough and can survive systemic shock, why do pressure injuries happen so easily? Like,
Oh,
why does an older patient simply lying in a hospital bed develop massive tissue necrosis on their tailbone?
that is the crucial physiological distinction every nurse must master. You have to separate systemic shunting from localized mechanical crushing.
Okay, break that down for me.
Systemic shunting during shock is a hormonally coordinated survival mechanism. Alpha adrenergic receptors cause vasoconstriction, yes,
Yeah.
but the physical architecture of the capillary bed remains completely intact.
All right.
The skin drops its metabolic rate, the cells go dormant, and they wait for the crisis to pass.
They just hold their breath.
Exactly, they hold their breath. But localized, unrelieved physical pressure, like the physical weight of a patient's pelvis pressing down onto a hospital mattress, applies severe mechanical force.
That's physical weight.
Right. Capillary closing pressure is generally around 32 millimeters of mercury. If the external pressure exceeds that, the physical weight physically crushes the flexible capillary walls between the hard bone of the sacrum and the surface of the bed.
You flatten the delivery system.
You're parking a car in a garden hose.
Oh, there's a perfect analogy.
Right. This creates localized ischemia, a complete absolute zero perfusion state in that specific crushed tissue bed.
Wow.
There is no blood coming in and no toxic metabolites being flushed out. If that pressure is not relieved through turning or shifting, the cells exhaust their anaerobic energy stores.
And then what happens?
Lactic acid builds up, destroying the cellular pH. The cells physically starve, rupture, and die. That is tissue necrosis, and it results in devastating dermal ulcers.
It is mechanical destruction of the vascular supply, not just a temporary pause in flow.
Exactly.
It completely changes how you have to picture a pressure injury. It's an ischemic crush injury.
Precisely.
Okay. Category 3, immunologic reactions. This is the body turning on itself.
This covers a vast spectrum of pathology, from localized contact dermatitis to severe systemic cell-mediated hypersensitivities.
The immune system mistakenly identifies a benign environmental substance as a lethal threat, or a genetic glitch causes it to attack its own healthy epithelial cells.
Right.
The common irritants are things like heavily fragrant soaps, harsh laundry detergents, and metals, specifically nickel, silver, and copper.
Very common triggers.
In a type 5 delayed hypersensitivity reaction, like poison ivy, the T cells take a few days to mount an attack, resulting in that blistery, incredibly itchy rash.
But then it scales up to chronic systemic inflammation like psoriasis.
Which isn't just dry skin, right?
No, psoriasis is an autoimmune disease where the T cells mistakenly trigger the basal stem cells in the epidermis to multiply at an insane rate.
How fast?
Instead of taking a month to migrate to the surface, the keratinocytes rush to the top in 3 or 4 days.
Oh, wow.
Yeah, creating massive, thick, silvery plaques of immature cells that constantly flake off.
And we have to take that immunologic failure even further to the absolute extreme.
Sure.
We must discuss severe, life-threatening hypersensitivities like Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, or 10N.
Those are terrifying conditions.
You see them mentioned in the tiny print on medication warnings, but what is actually happening to the patient?
SJS and 10 are usually a catastrophic, idiosyncratic hypersensitivity response to a medication, often an antibiotic or an anticonvulsant.
Okay.
The immune system's cytotoxic T cells go rogue. They express a protein called Fas ligand, which binds to receptors on the healthy keratinocytes and triggers massive, widespread apoptosis.
Cellular suicide.
Exactly. The entire epidermal layer dies simultaneously, separates from the dermis at the dermal-epidermal junction, and slows off the patient's body in giant, horrific sheets.
God, visually and physiologically, it behaves exactly like an extensive full-body thermal burn.
It does.
You have a massive, sudden loss of the protective barrier. The patient experiences critical, life-threatening, insensible fluid loss because there's no stratum corneum to hold the water in.
Right.
They develop profound hypothermia because the evaporative cooling is uncontrollable. And the risk for massive systemic bacterial sepsis is astronomical.
These patients must be managed in specialized burn-intensive care units. It is a critical emergency.
Which brings us to Category 4, infections and infestations, the microscopic invaders.
Let's look at bacterial infections first, because we need to distinguish between normal skin flora and pathogenic bacteria.
Because we are covered in billions of bacteria at all times, they own the real estate.
They do. The human microbiome is incredibly dense. The normal commensal flora on our skin, like Staphylococcus epidermidis, generally causes no harm.
Right.
In fact, through competitive exclusion, they consume the local nutrients and produce acidic byproducts that make the skin inhospitable to highly dangerous pathogenic invaders.
But if you have a microscopic abrasion, a tiny portal of entry, opportunistic pathogens can bypass the border guards and invade the deeper, highly vascularized tissues.
Cellulitis is the classic example here.
What's the mechanism there?
It's a deep bacterial infection, an inflammation of the subcutaneous connective tissues, and sometimes even the fascia, usually caused by Staphylococcus aureus or Streptococcus pyogenes.
And they spread fast, right?
Very fast. These bacteria produce enzymes like hyaluronidase that dissolve the connective tissue matrix, allowing the infection to spread rapidly outward.
Clinically, it presents as a hot, agonizingly tender, rapidly expanding red, edematous area on the leg or arm.
Yes. And then there's impetigo, which operates much higher up.
Right. Impetigo is entirely superficial, restricted to the epidermis.
It is highly contagious, also typically caused by staph or strep, and we see it constantly in pediatric populations.
Like kids in daycare.
Exactly. Children in daycares with minor scratches introduce the bacteria, which causes a localized inflammatory response, resulting in classic, fragile, honey-colored crusts around the mouth and nose.
Okay, let's pivot to fungal infections. The dermatophytes, the fungi that cause superficial infections, love to live on the dead keratin of the epidermis.
They do.
The heavy hitter here is Candida albicans, a yeast. It despises dry, exposed areas. It thrives in warm, dark, moist environments.
The oral mucosa, the vaginal canal, under heavy skin folds in obese patients.
The ecological balance of the skin is the critical concept here. Candida is actually a normal part of the human microbiome in small numbers, right?
It is. It is actively kept in check by the protective bacterial flora we just discussed. They compete for the same real estate and nutrients.
This is a huge, highly tested clinical cascade. We use antibiotics to heal bacterial infections, but broad-spectrum antibiotics are not sniper rifles. They are biological bulldozers.
They take out everything.
When you administer heavy 5E antibiotics to treat pneumonia or a surgical site infection, you wipe out the good, protective, normal flora along with the bad bacteria.
Right.
Suddenly, the Candida yeast looks around, realizes all its bacterial competitors are dead, and it flourishes. It multiplies exponentially.
So the very medicine meant to cure a primary infection directly induces a secondary fungal superinfection.
It's so ironic.
Every clinical nurse must anticipate this exact cascade.
Yeah.
The moment you start a patient on a broad-spectrum antibiotic regimen, you must simultaneously begin assessing their mucosal membranes.
What are we looking for?
You are looking for white, cottage, cheese-like plaques in the mouth, which is oral thrush or severe, bright red, macerated rashes in the perineal area.
Okay, we should also touch on the viral and infestation side. Viruses operate by hijacking the epithelial cell's internal machinery.
Right. Human papillomavirus causes the hyperproliferation of keratinocytes, resulting in a verruca, or common wart.
And the herpes simplex virus is notorious for its latency.
Oh, absolutely.
HSV-1, which causes cold sores on the facial mucosa, and HSV-2, which affects the genital mucosa, don't just go away. After the initial outbreak, the virus retreats and hides completely dormant inside the local sensory nerve ganglia,
Just
waiting for a moment of physiological stress or immunosuppression to travel back down the nerve and destroy the epithelial barrier all over again.
And infestations. This involves live, macroscopic organisms utilizing the human integumentary system as a habitat and a food source.
Gross, but true.
The scabies might physically burrow tunnels deep into the stratum corneum to lay its eggs and deposit feces.
And the immune system reacts to that.
Massively.
Right.
The human immune system mounts a type IV hypersensitivity reaction to the mite's feces, causing intense, uncontrollable pruritus or itching.
Lice, on the other hand, don't burrow. The pediculosis parasites are equipped with specialized claws to attach their eggs' nits firmly to the skin structures, specifically the hair shafts on the head, body, or pubic regions.
And they feed on human blood drawn from the scalp.
The primary clinical danger with infestations isn't just the parasite itself, though, is it?
No, it
Yeah.
is the secondary trauma. The extreme, unrelenting scratching physically destroys the epidermal integrity, creating massive open portals of entry for secondary staph and strep bacterial infections.
Category 5, thermal and radiation injury. This ranges from a common sunburn caused by UV radiation mutating the cellular DNA, up to extensive chemical scalds, open flames, and highly targeted radiation therapy burns used in oncology.
Yes, a huge range.
Walk me through the actual tissue-level pathophysiology of a severe thermal burn. What is the cellular timeline when a patient is exposed to a flame?
It is a highly choreographed systemic cascade. Jackson's burn wound model describes 3 distinct zones. The central area is the zone of coagulation. This tissue is immediately, irreversibly destroyed by the thermal energy. The proteins denature and the cells instantly die.
And around that,
Surrounding that is the zone of stasis, where tissue is ischemic and fighting for its life.
and what's the body's immediate systemic response?
Profound inflammation. Immediately following a deep burn, the local blood vessels clamp down in intense vasoconstriction to prevent immediate blood loss.
Okay.
But within minutes, massive vasodilation and increased capillary permeability take over. The endothelial cells lining the blood vessels literally shrink and pull apart.
Which causes what?
This causes massive edema or swelling as protein-rich plasma leaks out of the vascular space and floods the interstitial tissues.
Oh, wow.
This fluid shift can be so massive in large burns that it causes hypovolemic shock.
Because the blood volume just plummets because the plasma is pooling in the tissue.
Exactly.
But eventually the rebuilding crew has to arise, right?
Yes, the immune and repair cells navigate through that edema. Macrophages, which are large, highly mobile white blood cells, infiltrate the burn site. They are the microscopic cleanup crew.
What do they do?
They phagocytize or engulf and digest the charred cellular debris and dead bacteria to naturally debride the wound.
Wow.
Following them, fibroblasts migrate in and begin synthesizing disorganized collagen and elastin to provide temporary scaffolding.
And then the blood supply.
Finally, angiogenesis occurs. New, fragile vascular networks sprout to supply oxygen, and surviving epithelial cells from the wound edges or deep hair follicles begin to wildly divide and migrate across the surface to close the defect.
It is a microscopic construction site operating in a war zone.
It really is.
Finally, category 6 is lesions. This covers abnormal cellular proliferation, ranging from benign skin growths like lipomas or skin tags to invasive, lethal, malignant tumors.
The most common skin cancers are melanoma, basal cell carcinoma, and squamous cell carcinoma.
And even a benign growth is a disruption of tissue integrity if it compresses surrounding vascular structures or causes severe psychosocial distress due to facial disfigurement.
Right. But malignancy is a profound failure of structural integrity.
How so?
In a squamous cell carcinoma, for instance, the keratinocyte sustains severe UV DNA damage, bypass cellular checkpoints, and divide uncontrollably. They form an invasive, ulcerating mass that literally consumes the healthy surrounding tissue.
So that transitions us logically to the next phase. Once the tissue is damaged by any of these 6 mechanisms, whether it's crushed into ischemia by a mattress, sloughed off with a drug allergy, dissolved by bacterial enzymes, or physically charred by fire, the body has to rebuild.
Yeah.
But as you must understand, for clinical practice, healing is absolutely not a one-size-fits-all process. The geometry and cleanliness of the wound dictate the biological strategy.
Clinically, wound healing is categorized into 3 specific processes or intentions: primary, secondary, and tertiary intention.
If you're struggling with intention terminology, think of primary intention like supergluing a clean paper cut.
A great way to picture it.
The wound margins are surgically neat. They're brought tightly together or approximated, to use the clinical term, often with sutures, staples, or surgical glue.
Because the physical gap is microscopic, the fibroblasts only have to lay down a tiny amount of collagen.
Healing is incredibly fast, the infection risk is exceptionally low, and it leaves a thin, minimal scar.
Right. Primary intention demands anatomically perfect approximation. The tissue layers align perfectly. But if there is significant tissue loss, the body must switch to secondary intention.
Secondary intention is like filling in a massive pothole in the street. Picture a large, open stage 3 pressure ulcer. You physically cannot pull the wound edges together because there's simply too much missing adipose and dermal tissue.
The tension would rip the sutures right out.
So the body has to slowly fill that entire cavernous gap from the bottom up.
It fills it with granulation tissue. This process requires vast amounts of metabolic energy. The fibroblasts must synthesize massive volumes of collagen matrix, and immense capillary networks must grow to supply it.
And because the wound is open to the air for weeks or months, the infection risk is astronomical, right?
Exactly. And because the defect is so large, myofibroblasts eventually pull the edges inward, leaving a massive contracted fibrotic scar.
And finally, tertiary intention. This is delayed primary closure. Think of leaving that massive pothole open on purpose, putting traffic cones around it because the hole is full of toxic waste.
A very vivid analogy.
Imagine a ruptured appendix contaminating a surgical abdominal wound. You absolutely do not suture that closed immediately. If you seal massive bacterial contamination inside a warm, dark, nutrient-rich abdominal cavity, you are building an incubator for a lethal systemic abscess.
The clinical reality of tertiary intention is patience. You leave the wound packed open intentionally.
You administer heavy antibiotics, you allow the macrophages to aggressively clear the bioburden, and you wait for the inflammatory phase to subside over several days.
Right. Once the clinical assessment confirms the wound bed is totally clean and granulating, then the surgeon goes back in, pulls the edges together, and sutures it closed.
So it artificially prolongs the inflammatory phase, which results in the most extensive, prominent scarring of all three types.
It does.
So speaking of these phases, inflammatory, granulation, maturation, let's break down the actual biochemical timeline of wound healing. How does the body orchestrate this?
The inflammatory phase is the immediate chaotic response to injury, lasting roughly 3 to 5 days. The absolute first priority is hemostasis, stopping the bleeding.
Severed blood vessels instantly vasospasm, clamping down.
Platelets flood the area, adhere to the exposed collagen, and form a physical plug. They then degranulate, releasing critical chemical messengers like platelet-derived growth factor.
They sound the biochemical alarm.
Exactly. That alarm triggers the coagulation cascade to form a stable fibrin clot. Once the bleeding stops, the blood vessels actually massively dilate, driven by histamine release from mast cells.
Which causes the classic signs of inflammation: redness, heat, swelling, and pain.
Right. Neutrophils rush in first to kill immediate bacterial threats, followed by the heavy artillery, the macrophages, which phagocytize the dead tissue and release cytokines to initiate the next phase.
Then we enter the granulation phase, also known as the proliferative phase. If you are doing a dressing change on a wound during this phase, what are you physically looking for?
You are looking for a highly vascular, incredibly pink, or beefy red wound bed with a bumpy, granular texture.
This is the hallmark of a healthy healing wound.
It means angiogenesis is in full swing. Tiny, fragile new capillary loops are physically sprouting into the wound matrix to supply oxygen.
Fibroblasts are working overtime, laying down type 3 collagen to build the scaffold.
And concurrently, epithelial cells at the wound margins flatten out and physically migrate, or leapfrog, across the moist surface of this new granulation tissue until they meet in the middle.
Which is called epithelialization. And finally, the maturation phase, or the remodeling phase. This isn't a matter of days. This takes months or even years. The wound looks closed on the outside, the skin is intact, but a massive construction project is still happening underneath.
The initial type 3 collagen laid down during granulation is disorganized and structurally weak.
So how does it get stronger?
During maturation, specialized enzymes called matrix metalloproteinases break down that weak collagen, while fibroblasts replace it with thick, highly organized type collagen fibers.
Oh, I see.
They align perfectly along the lines of mechanical tension. The scar physically contracts and flattens.
However, listeners must remember this clinical fact. Scar tissue is completely devoid of hair follicles, sweat glands, and melanin, and it will only ever regain about 80% of the original tissue's tensile strength.
It is permanently compromised armor.
So what if this highly orchestrated process fails? What if a patient is malnourished or diabetic, and the wound arrests in the inflammatory phase? What is the systemic domino effect when tissue integrity is permanently compromised? Because we established early on that the skin isn't just a wrapper.
The systemic consequences of widespread impaired tissue integrity are catastrophic. First, consider thermoregulation and fluid balance.
Okay.
If a patient loses an overwhelming surface area of epidermis, like in a severe burn or toxic epidermal necrolysis, they completely lose the physical barrier trapping internal water.
The insensible fluid evaporation is massive.
This leads to profound hypovolemia, electrolyte derangement, and an inability to maintain core body heat. Massive, calculated intravenous fluid resuscitation is immediately required just to keep the heart pumping.
Second, protection from infection. That physical acidic microbiome protected barrier is gone.
For a patient who is already immunocompromised, even a small, unhealed diabetic foot ulcer is a direct, open highway for virulent pathogens to enter the bloodstream, multiply, and trigger septic shock.
We must also recognize the neurological deficit. If a deep wound destroys the dermal nerve endings, the patient loses protective sensation.
Right, they lose the feedback loop that tells them a bath is scalding hot or a shoe is causing ischemic pressure, which inevitably leads to further, deeper, unperceived traumatic injuries.
And we absolutely cannot ignore the psychosocial impact. The skin is our interface with the world. It is deeply tied to our identity and how we are perceived.
Chronic malodorous wounds, massive keloid scars, or severe facial lesions are highly visible.
The resulting body image disturbance, social isolation, and severe clinical depression can be profoundly debilitating for the patient.
Healing the physical wound is only half the battle. Managing the psychosocial trauma is equally critical to holistic nursing care.
Okay, so to prevent these massive systemic failures, a nurse has to act as an exceptional clinical detective. You have to spot the warning signs and the physiological vulnerabilities long before the skin actually breaks down.
You do.
How do we identify the at-risk patient?
Risk identification requires synthesizing the patient's entire medical history and their current physical environment.
Individual risk factors almost always trace back to systemic health deficits.
Poor peripheral perfusion, like in peripheral artery disease, uncontrolled diabetes, or severe heart failure, means the distal tissue beds are already living in a state of chronic hypoxia.
They are starving for oxygen before any pressure is even applied.
Malnutrition is a massive red flag. If a patient's serum albumin is low or they lack protein, they simply do not have the amino acid building blocks required for fibroblasts to synthesize collagen.
Obesity places exponentially higher mechanical weight on bony prominences, crushing capillary beds faster.
And immobility, whether from a spinal cord injury, a stroke, or simply heavy sedation in the ICU, means the patient cannot independently enact the microshifts in weight that naturally relieve localized ischemia.
And profound immunosuppression, whether from HIV, chemotherapy, or prolonged corticosteroid use, guarantees that the normal inflammatory phase of wound healing will be severely blunted.
Any tiny break in the skin will struggle to heal and will inevitably become colonized with bacteria.
We also have to assess for specific genetic vulnerabilities that compromise tissue integrity from birth. Conditions like albinism, where a genetic mutation halts the production of melanin.
That completely removes the body's natural UV shield and guarantees severe cellular damage from even minor sun exposure.
Or epidermolysis bullosa, a heartbreaking genetic condition where the anchoring fibrils that normally bind the epidermis to the dermis are defective.
The layers literally do not hold together, causing severe, excruciating blistering and slouging from the friction of simply wearing clothes.
We must also routinely assess for skin cancer risks. The pathophysiology of melanoma is heavily tied to cumulative UV exposure and genetic predisposition.
The highest risk populations are fair-skinned individuals, particularly those over 65 who have accumulated decades of cellular mutations.
Individuals with a history of severe blistering sunburns in childhood, those with an abundance of atypical moles, or simply having more than 50 benign moles on their body.
But for the acutely hospitalized patient, the most immediate preventable threat you are assessing for every single shift is the pressure injury.
And this requires utilizing a standardized, validated, predictive clinical tool.
If you are taking a nursing exam, you will encounter the Braden scale for predicting pressure sore risk. It is the gold standard assessment tool.
And it does not look at the skin itself, right?
No. It mathematically evaluates 6 distinct physiological and environmental subscales to calculate a patient's overall vulnerability to ischemia.
Let's dive deep into these 6 parameters. Sensory perception, moisture, activity, mobility, nutrition, and friction and shear. Let's look at why each of those matters physiologically.
Sensory perception evaluates the neurological loop. Can the patient physically feel the agonizing pain of localized ischemia, and can they communicate that discomfort?
If they are comatose or paraplegic, they score terribly here.
Moisture evaluates the microclimate of the skin. Is the epidermis constantly exposed to urine or feces from incontinence or heavy perspiration?
Prolonged moisture chemically macerates the stratum corneum, softening the keratin and making it exponentially easier for friction to tear it apart.
Activity looks at whether they can physically get out of bed into a chair or walk.
Mobility is slightly different.
Yes, it evaluates whether they can change and control their body position while in bed. Even small, independent shifts in weight allow the crushed capillary beds to refill with oxygenated blood.
Nutrition, as we discussed, looks at their food intake. Are they consuming enough protein to maintain tissue resilience and repair daily microtears?
And finally, friction and shear. This evaluates the mechanical forces acting on the skin.
Friction is two surfaces rubbing together like heels dragging across a coarse hospital sheet, which strips away the epidermis.
But shear is much more insidious.
Shear is what happens when you elevate the head of the patient's bed to 60 degrees. The patient's heavy skeleton and deep muscle layers succumb to gravity and slide downward toward the foot of the bed.
Right. However, the external skin of their sacrum stays stuck to the friction of the mattress.
So the deep tissues move down, the superficial tissues stay put, and the tiny perforator blood vessels connecting the two are violently stretched, kinked, or completely torn apart deep beneath the surface.
Shear destroys the vascular supply from the inside out. Now, each of these 6 categories is scored, usually from 1 to 4.
The absolute key metric for your exam is this. The scale totals 23 points. A score of less than 18 means the adult patient is officially at high risk for developing dermal ulcers.
The moment that score drops below 18, the clinical alarm bells ring.
And you must institute aggressive, documented preventive protocols, strict turning schedules, specialized air mattresses, and barrier creams.
But what happens when the prevention fails, the ischemia wins, and a pressure injury develops?
You must be able to stage it accurately for clinical charting, insurance reimbursement, and proper treatment planning.
Let's walk through the National Pressure Ulcer Advisory Panel staging criteria methodically. The differences between these stages are subtle, highly tested, and dictate entirely different clinical interventions.
Okay, let's start with stage 1. Stage 1 is defined as intact skin with a localized area of non-blanchable erythema. Erythema meaning intense redness. So what does that actually look like, and what is the underlying pathophysiology?
Picture a bedbound patient's heel. It's bright red. You press 2 fingers firmly into that red area and hold for a second.
Okay.
In healthy, well-perfused pink skin, that pressure physically squeezes the blood out of the capillary bed. When you lift your fingers, the skin is briefly white that's blanching, and then the capillary refills and the pink color immediately returns.
That is a normal reactive hyperemia.
But in a stage 1 injury, the physiology is broken. In a stage 1, when you press that redness, it does not blanch.
It stays stubbornly, persistently red or maroon.
Yes. The skin surface is completely unbroken, there is no open crater, but that non-blanchable redness is a massive clinical red flag.
It tells you that structural, irreversible microvascular damage has already occurred in the capillary beds below. The vessels are engorged and damaged, unable to clear the localized congestion.
It is the earliest visual warning sign of impending necrosis.
Okay, stage 2. The barrier is officially broken.
Stage 2 involves partial thickness, loss of the skin with exposed dermis. The epidermis has physically ruptured or sheared off.
Because the dermis is highly vascular, the wound bed is viable, usually a moist, shiny pink or red.
Crucially, a stage 2 can also present as an intact or ruptured serum-filled blister.
So if a patient has a blister on their heel from a tight shoe rubbing all day, that is automatically classified as a stage 2 pressure injury.
Correct. The key differentiator for an exam, however, is what you cannot see in stage 2. You cannot see subcutaneous adipose tissue.
If you see yellow fat, you have crossed the boundary. You are no longer in stage 2.
Which brings us to stage 3. The damage is deepening. Stage 3 is full-thickness skin loss. The epidermis and the entire dermis are completely destroyed.
Subcutaneous adipose fat is now clearly visible in the base of the ulcer.
You will often see healthy granulation tissue trying to form, but you will also frequently see a phenomenon called epibole.
Epiole is fascinating. It's when the epithelial cells at the wound edges roll inward, like a tucked-in shirt collar.
Right.
The cells migrate down the sides of the crater, hit the bottom, and roll under. And because epithelial cells are programmed to stop dividing once they touch each other, contact inhibition, they roll under, touch themselves, and falsely signal the body that the wound is closed.
Healing completely stops, even though there's a massive hole left.
It is a massive barrier to healing that often requires surgical intervention to recut the edges.
In stage 3, you might also see slow, yellowish, stringy, necrotic tissue, but importantly, you do not see muscle, tendon, or bone.
Because the moment you see muscle, glistening tendon, or hard bone, you are looking at a stage 4.
Exactly. Stage 4 is catastrophic full-thickness tissue loss. The necrotic damage has tunneled completely through the fat layer.
Fascia, deep skeletal muscle, ligaments, cartilage, or bone are directly palpable or exposed to the room air.
The clinical danger here isn't just tissue loss, it is the massive risk of osteomyelitis, a deep, stubborn, often incurable bacterial infection of the bone itself.
Now, there are two caveats to the staging system that are highly tested because they break the standard rules. The first is the unstageable pressure injury.
The golden, unbreakable rule of pressure injury assessment is this: you cannot stage what you cannot physically see.
If a wound crater is completely obscured by a thick, opaque layer of slough, or covered by eschar, which is a dry, dark, brown, or black, leathery scab of totally necrotic tissue, you cannot visualize the true depth of the wound base.
It's a biological blindfold. It might be a stage 3 hiding under there. It might be a stage 4 tunneling into the bone. You cannot know.
Therefore, until that eschar is chemically or surgically debrided and the viable wound base is clearly visible, the injury must be classified as unstageable.
And the second caveat is the deep tissue pressure injury, or DTPI. This one is tricky because it looks deceptively mild on the surface.
It's a clinical trap.
Yeah.
A DTPI presents as a localized area of persistent, non-blanchable deep red, maroon, or dark purple discoloration.
It can look exactly like a severe dark bruise on a patient's sacrum.
The epidermal surface might actually be completely intact. But unlike a superficial stage 1, this dark purple discoloration indicates a massive, horrific shear injury deep at the bone-muscle interface.
Muscle tissue is actually far more sensitive to hypoxia than skin tissue.
So when a patient experiences severe shear forces, the muscle layer dying against the bone happens long before the skin surface shows any distress. The necrosis starts at the bone and works its way up.
Precisely. The damage is profound, it's just happening entirely under the surface. Over the course of a few days, that intact purple skin may rapidly evolve, rupture, and suddenly open up to reveal a massive necrotic stage 3 or 4 crater.
It is a ticking time bomb. Okay, beyond meticulously staging wounds, a nurse has to master the overall physical examination of the integumentary system. There is a fascinating clinical pearl regarding assessing skin turgor, which is how we check hydration status and tissue elasticity.
Yes, checking skin turgor involves lightly pinching a fold of skin and watching how rapidly it recoils or snaps back into place. Fast recoil indicates healthy intracellular hydration and robust elastin fibers.
Right. But if you check an older adult's turgor on the back of their hand, which is where everyone intuitively wants to check it because it's easily accessible, you will almost always get a false positive for severe dehydration.
Because of their natural age-related atrophy of subcutaneous tissue and the severe loss of dermal elastin in their hands?
The skin will stay tented up for several seconds, even if their fluid balance is completely perfect. You have to check their turgor on the forearm, or, preferably, under the clavicle on the chest, to get a physiologically accurate reading.
That is a classic exam trap. Another vital assessment skill is understanding how to accurately assess for generalized systemic color changes, particularly cyanosis, a bluish tint indicating severe systemic hypoxia in dark-skinned individuals.
Because a dangerous drop in oxygen saturation isn't going to present as a glaring blue-gray smurf color on deep brown skin, the heavy melanin completely masks the visual cue.
Correct. It might appear as a subtle ashen gray or dulling of the natural skin tone, but that is unreliable.
The only physiologically sound method is to inspect the areas of the body with the absolute least natural pigmentation, where the capillary beds are visible through thin mucosa.
You must look at the subglossal mucosa under the tongue, the buccal mucosa inside the cheeks, the palpebral conjunctiva inside the lower eyelids, and the white sclera of the eyes.
If those tissues are blue or pale gray, the patient is critically hypoxic. You have to know exactly where to look. Finally, for the physical assessment, let's cover the mnemonic for melanoma screening. We talked about identifying the high-risk populations, but how do you evaluate the specific lesion itself? It's the ABCDE mnemonic.
A highly practical, globally recognized tool. A is for asymmetry. If you draw a line down the middle of the mole, one half does not match the other in shape or size.
B is for border irregularity. Benign moles have smooth, distinct edges. Melanomas have ragged, notched, or blurred borders as the malignant cells invade surrounding tissue in an uncontrolled manner.
C is for color. A benign mole is uniformly one shade of brown. A melanoma has a wildly uneven color distribution, a chaotic mix of black, brown, tan, maybe even inflammatory pink or necrotic blue.
D is for diameter. Melanomas are generally larger than 6 millimeters across, which is roughly the size of a standard pencil eraser.
And E is for evolving. This is the absolute biggest red flag. A benign lesion is static.
If the patient reports that the mole is actively changing in size, altering its shape, changing color, or suddenly developing symptoms like intense itching or spontaneous bleeding over the past few weeks, that indicates rapid, uncontrolled cellular division.
It requires immediate dermatological biopsy.
Evolving is the siren. So we've identified the systemic risks, we've staged the horrific ischemic wounds, and we've physically assessed the patient from their clavicle turgor to their conjunctiva. Now, what does the nurse actually do about it? Let's transition to the action plan clinical management. Let's start with primary prevention. How do we reinforce the biology to stop the armor from breaking in the first place?
Primary prevention hinges on three main pillars: meticulous hygiene, aggressive nutritional support, and physical protection from environmental hazards.
Let's talk nutrition, because we touched on this earlier with the Braden scale. Protein is the obvious building block, but let's look at the biochemical requirements for healing.
To synthesize healthy, cross-linked collagen, the fibroblasts don't just need amino acids from protein. They have an absolute non-negotiable biochemical requirement for vitamin C.
Vitamin C is the essential cofactor for the enzymes that hydroxylate proline and lysine, which allows the collagen fibers to twist into their incredibly strong triple helix structure.
Without vitamin C, the body produces weak, defective collagen, and old wounds literally break open, which is the classic pathology of scurvy. Zinc is also vital for cellular proliferation.
And even a short period of clinical fasting, like placing a patient MPO for a few days before and after a major bowel surgery, can completely halt collagen synthesis and significantly delay wound healing.
Initiating early enteral feeding, getting liquid nutrition into their gut as soon as medically safe, is a vital nursing intervention to keep the fibroblasts working.
And regarding environmental protection, sun exposure prevention is heavily emphasized: daily sunscreen, UV blocking clothing. But we must also highlight a highly practical, devastatingly common environmental hazard: thermal scalds in the home.
There's a massive hidden risk in geriatric and pediatric homes that people completely ignore.
Hot water heaters.
If a home's water heater is set above 120 degrees Fahrenheit, the time it takes for water to cause a full thickness, third-degree burn drops exponentially. At 140 degrees, it takes literally 3 seconds to destroy the epidermis and dermis.
Home water heaters must be mechanically capped at a maximum of 120 degrees. It is a simple, systemic engineering fix that saves lives, especially for older adults with peripheral neuropathy who might step into a scalding bath and physically not feel that the tissue is being destroyed until it is too late.
There's also a huge clinical warning for parents. Never, ever heat baby formula or breast milk in a microwave. The physics of a microwave creates intense molecular friction, resulting in highly uneven heating. A plastic bottle might feel perfectly lukewarm to the parent's touch on the outside, but localized pockets of fluid inside could be superheated to near boiling.
When the infant drinks, those superheated pockets will catastrophically scald the infant's highly delicate, thin oral and esophageal mucosa, causing severe swelling that can compromise the airway.
It's completely avoidable trauma.
Now, what happens when prevention isn't enough and the tissue is actively diseased or failing? Let's look at collaborative interventions in pharmacotherapy. We rely on heavy pharmacological artillery.
The first line of defense often involves targeting the bioburden with antibiotics. These can be topical ointments like bacitracin for superficial epidermal cuts, oral systemic pills for minor localized infections, or massive intravenous regimens like vancomycin for deep tissue cellulitis or sepsis.
Then we have the immune modulators, steroids. Steroids are the biochemical fire extinguishers for the immune system.
They are. Corticosteroids work by inhibiting the arachidonic acid cascade, powerfully suppressing the entire inflammatory response. Topical steroids are applied directly to localized allergic contact dermatitis to shut down the hyperactive T cells and stop the intense pruritus.
Oral or parenteral IV steroids are deployed when the allergic reaction is severe and systemic, like widespread urticaria or acute exacerbations of autoimmune skin disorders.
We also rely heavily on emollients. These are your specialized lotions, creams, and petroleum-based ointments.
They don't just feel nice. Physiologically, they work by trapping internal moisture inside the weakened skin barrier, reinforcing the stratum corneum, or they act as a stable delivery base to hold active pharmacological drugs against the skin.
And on the far end of the severity spectrum, we have chemotherapy and aggressive immunosuppressants. Most people associate chemotherapy strictly with oncology.
But drugs like methotrexate are frequently used for severe, widespread autoimmune skin disorders like crippling psoriasis.
The goal is to aggressively halt the hyperactive, uncontrolled cellular division of the keratinocytes, giving the epidermal layer time to normalize.
Let's pull away from the pharmacy and talk about actual, hands-on wound care and surgical treatments. Here's where the clinical reality violently clashes with what people see on television. When you have a patient with a fresh, healthy, granulating wound, the instinct is to aggressively disinfect it.
People think that's the right thing to do.
Why don't we just pour harsh disinfectants like hydrogen peroxide or diluted bleach into the wound bed to kill absolutely every bacteria present? It foams up, it bubbles, it looks like it's powerfully cleaning the wound.
That visual foaming is satisfying, but physiologically it is disastrous for the wound healing timeline. That bubbling is oxidative stress.
Harsh chemical solutions like hydrogen peroxide, povidone iodine, or acetic acid are highly cytotoxic. They are indiscriminate killers.
They don't just destroy the bacterial cell walls, they cause severe lipid peroxidation that literally rips apart the fragile cell membranes of the newly formed, healthy fibroblasts, endothelial cells, and macrophages, trying to bridge the wound gap.
You are systematically carpet bombing your own microscopic construction crew.
You are actively inducing necrosis and resetting the healing timeline back to day one. Those harsh cytotoxic solutions are strictly reserved for massively contaminated, grossly dirty wounds like a bite wound or an agricultural injury, where the immediate risk of lethal systemic sepsis vastly outweighs the localized tissue damage.
For a healthy red, granulating wound, gentle irrigation with warmed, normal saline or extremely mild soap and water is all that is physiologically required to flush away excess exudate without harming the fragile new cellular matrix.
That is a massive clinical concept to lock in. Do not kill the fibroblasts.
What about dressings? You don't just slap a piece of dry woven gauze on everything and tape it down.
Absolutely not. The microclimate of the wound base dictates the exact type of dressing required. Historically, wounds were allowed to dry out and form hard scabs. We now know that dry, desiccated tissue halts cellular migration.
The goal of modern wound care is to maintain a slightly moist, not completely waterlogged and soggy, but damp environment, because epithelial cells literally have to swim or slide across the wound bed to close it. They can't migrate across a dry desert of a scab.
Exactly. Moist tissue repairs exponentially faster. If a wound is completely dry, we use hydrogel dressings to donate water to the tissue.
If a wound is weeping moderate amounts of fluid, we use hydrocolloid or foam dressings to absorb the excess exudate while trapping just enough moisture to keep the balance biologically perfect.
Dry gauze is really only used to pack dead space or absorb massive uncontrolled bleeding.
And what if the wound is cavernous, heavily draining, and refusing to granulate?
Then we deploy a vacuum-assisted closure system, commonly called a wound VAC. This is a highly specialized piece of equipment. You pack the wound with a specific porous sponge, cover the entire area with a perfectly sealed, airtight plastic drape, and attach a localized pump that applies continuous or intermittent negative atmospheric pressure to the wound bed.
It's actively sucking on the wound 20/47. What does that actually do to the cells?
It does three profound things. First, it physically vacuums out massive volumes of inhibitory exudate and infectious material. Second, the negative pressure reduces the localized interstitial edema, which physically brings the capillaries closer together to improve oxygen diffusion.
Third, and most importantly, the physical tension of the suction causes microdeformation of the cells. It physically stretches the fibroblasts, which mechanotransduction triggers to rapidly increase cellular division and dramatically accelerates angiogenesis.
It is like a biological hyperdrive for creating granulation tissue.
That's incredible. It tricks the cells into multiplying by stretching them. Now, earlier we talked about Escher, that thick, black, leathery armor of dead tissue that makes a wound unstageable. You cannot heal through Escher. The body views it as a biological roadblock. It has to be removed. That removal process is called debridement.
Debridement is the absolute prerequisite for wound healing. It is the removal of non-viable necrotic tissue to expose the healthy, bleeding tissue underneath. You have several clinical options.
Surgical or sharp debridement is the fastest to EBLIOA. A trained surgeon or specialized nurse literally takes a sterile scalpel and physically cuts the dead tissue away until they hit a healthy, bleeding vascular bed.
But often, due to bleeding risks or severe comorbidities, a patient simply isn't a safe candidate for sharp surgical debridement.
So if you can't cut it out, what do you do?
You utilize enzymatic or pharmacologic debridement. This involves applying a highly specific prescription topical ointment directly to the necrotic tissue. The most common is collagenase ointment.
It acts slowly, over days or weeks, chemically breaking down the precise peptide bonds holding the dead necrotic collagen together.
It digests the ester from the inside out without causing any chemical harm to the adjacent healthy living cells. It is a highly targeted microscopic chemical cleanup.
And once the wound is finally clean, red, and granulating,
Yeah.
if the crater is simply too massive to heal by secondary intention, if the pothole is too huge and the patient will succumb to fluid loss before it closes, that's when the surgical team moves to skin grafting.
Yes. Grafting involves physically harvesting healthy, intact epidermis and partial dermis from a donor site on the patient's own body, like the thigh, and surgically transplanting it over the massive defect.
Huh.
Or utilizing advanced bioengineered skin substitutes to physically bridge the gap. You are artificially surgically replacing the failed barrier.
As we wrap up this intensive action plan, we need to conclude with a powerful, overarching clinical reminder. I think this is the absolute perfect way to synthesize everything we've dissected today. Tissue integrity absolutely does not exist in a vacuum. It is deeply, inextricably linked to every other vital system in the human body.
It is the ultimate interrelated concept. Let's logically trace the physiological connections. Tissue integrity relies entirely on gas exchange. If the lungs aren't oxygenating the blood, the tissue suffocates.
It relies on perfusion. If the heart can't pump that oxygen to the periphery, the tissue starves. It relies on nutrition. Without dietary protein and vitamin C, the collagen scaffolding collapses.
It relies on mobility. If the musculoskeletal system cannot shift the skeleton's weight, the capillary beds are mechanically crushed.
And when tissue integrity fails, it creates a massive, devastating negative feedback loop that crashes the rest of the body. A massive burn instantly destroys thermoregulation and causes profound lethal fluid and electrolyte imbalances.
A deep, tunneling stage 4 pressure ulcer opens a direct biological highway for devastating bacterial infection and sepsis. The destruction of sensory nerves causes tremendous intractable pain or dangerous numbness.
And the visible, disfiguring scarring severely impacts the patient's psychological well-being and sense of self. It is all connected.
If you are taking a nursing exam, or if you are physically assessing a patient on the clinical floor, you absolutely cannot look at a wound in isolation. You cannot just see a hole in the skin. You must view it as the visual endpoint of a systemic event.
And there it is, to the learner listening to this. Congratulations, you have just completed an intensive, microscopic, and systemic review of tissue integrity.
We tracked this vital armor from its cellular baseline in the stratum basal through the varied, violent mechanisms of injury, from shear force ischemia to T-cell hypersensitivity.
We mapped out the miraculous, highly choreographed biochemical phases of healing, and we drilled down deep into the rigorous clinical staging of pressure injuries and the precise medical management required to protect and heal your patients. You are ready for this exam. You possess the foundational pathophysiology now. You don't just know what a stage 3 ulcer looks like on a textbook diagram. You know exactly why the adipose tissue is visible, why the epibole halts healing, and why the capillary beds failed to survive the mechanical shear force.
That deep causal understanding is what makes a truly exceptional, life-saving clinician.
Before we sign off, I want to leave you with a final, provocative thought to mull over. Something that builds on the biology we've discussed today. We have talked extensively about how the skin reacts to the outside environment, how it deflects pathogenic bacteria, how it burns from thermal energy, how it breaks under mattress pressure. But what about the skin as a diagnostic mirror for the inside?
It's an incredibly fascinating frontier in diagnostic medicine.
Right now, with the rapidly emerging science of the skin microbiome, researchers are exploring whether tiny, currently invisible changes in our skin's bacterial flora or microscopic shifts in epidermal integrity and lipid composition could actually be used to predict systemic internal diseases.
We're talking about utilizing non-invasive skin swabs to predict the onset of autoimmune disorders, silent metabolic failures, or even early-stage neurological decline, months or even years before traditional internal symptoms ever appear on a standard blood test.
So the clinical question I leave you with is this. Could the skin of the future be less of an armor that we simply have to protect and more of a real-time, highly sensitive digital dashboard for our entire internal health?
That is a brilliant physiological question to ponder as we look toward the future of advanced clinical practice.
Best of luck on your exam.